There's been significant advances in the treatment of metastatic castration-resistant prostate cancer over the past many years. However, the role of immunotherapies remains to be determined. Many immunotherapies have been trialled in prostate cancer, in particular the checkpoint inhibitors, with very disappointing results. So there really is a need to utilize the potential benefits of immunotherapy and the long-term benefits of immunotherapy seen in other cancers in that of metastatic castration-resistant prostate cancer. And so the phase 1 study I presented at ESMO 2020 is that of an agent called AMG 160. AMG 160 is considered a T-cell recruiting immunotherapy, but more specifically, it is a bispecific T-cell engager. Bispecific T-cell engagers, as their name entails, have two arms. One arm targets T-cells and recruits T-cells towards the prostate cancer immune microenvironment, and the other arm targets prostate cancer itself, targeting PSMA, which is a known and validated target for both the imaging and treatment of prostate cancer. So the study we presented is a phase 1 study of AMG 160 in patients with metastatic castration-resistant prostate cancer. And these are preliminary results that have been discussed at ESMO. We presented the results from the first 43 patients treated on this study, or from the dose exploration part of the study. As with any phase 1 study, the major aims are to determine safety and to determine the recommended phase 2 dose. We also have secondary endpoints of evaluating preliminary evidence of efficacy. So the phase 1 study is made up of 3 components. One, the dose exploration component, which are the results, preliminary results I'll be presenting. There is a dose expansion cohort where we're treating larger numbers of patients at the recommended phase 2 dose. And there's also a component where AMG 160 is combined with pembrolizumab. This is based upon preclinical data that suggests that using AMG 160 upregulates PD-1/PD-L1, and hence the combination with PD-1 inhibitors such as pembrolizumab would make sense. Whilst that component of the study has been started, those results will not be presented and have not been presented at ESMO 2020. So the results that I did present are, as I said, of the first 43 patients treated on study. All patients received at least 1 dose of AMG 160. There were some side effects seen, although it was largely a tolerable treatment. The major side effect seen was that of cytokine release syndrome. This is something that is expected with this class of treatment. Cytokine release syndrome can result in patients experiencing fevers. Sometimes there's chills or rigors. This can lead to transaminitis, as well as hypotension and some nausea, vomiting, and diarrhea in some patients. The doses, as the doses increase, the incidence of CRS has increased. However, the study has used mitigation strategies to reduce the incidence of CRS. These mitigation strategies have included a lower priming lead-in dose before the target dose is achieved, the use of steroid pre-medication, and also the use of prophylactic intravenous hydration to prevent issues with hypotension. As I mentioned, the CRS was predominantly hypotension and transaminitis. The transaminitis itself was usually self-limiting and resolved within 1 to 3 days. We did see very exciting preliminary evidence of efficacy with AMG 160 in our patient population. 69% of patients had a reduction in PSA, with 34% of patients having their PSA dropped by 50% or more. This is particularly impressive given that as a phase 1 study, the patient population is heavily pre-treated, with 60% of patients having 4 or more prior lines of therapy coming into this study. Of the 43 patients treated, 15 patients were evaluable for RECIST responses, and of that, 3 out of 15 had a partial response. 2 of those are confirmed and 1 is unconfirmed. So overall, we're very excited about AMG 160. It's really, even though it's very early days in the development of this agent, and even though we're still completing our phase 1 dose exploration portion and still trying to determine our recommended phase 2 dose, the fact that it's managed, the toxicity is manageable, and the fact that the efficacy is better than seen with any other prior immunotherapy in prostate cancer is very exciting. We hope to achieve our recommended phase 2 dose soon and begin the dose expansion portion of the study. And there are not yet any plans for future further development, although talks are still ongoing about how best to place AMG 160 in the treatment landscape for mCRPC.